हेलो। हाँ, स्टार्टिंग। हाँ, check. Yes, hello everyone. Very good evening to all of you. Welcome to yet another session of video-based MCQ series from the side of PW Merid. I am Dr. Sanchit Vajpayee, ENT faculty at PW Merid, and हम लोगों ने बहुत सारी बातें करी. We've been doing a lot of video-based MCQs for multiple subjects. As you can see, the series is going on, and this would be my final session from ENT, right? So in the last previous sessions, we have covered about the video-based MCQs of larynx, right? We had a specific session on larynx. Then we went on to understand about the video-based MCQs that are important for your perspective from ear point of view. तो हमने ear के MCQs किए, and today I have given a kind of a spectrum of important video-based MCQs that come from nasal cavity as well as nasopharynx. Right? Yes. Good evening. Welcome, Parth. Yes, and welcome to all of you who have joined today. So in this particular session, I will be only concentrating on nose, right? मैंने सारी चीजें divide करी हुई हैं. So in the previous sections, I've given up different MCQs from different segments. This will be only for nose as well as nasopharyngeal pathologies. And we are going to take up 10 important videos, and we are going to solve out those particular disorders which you can see over on those video endoscopies, right? So chalo. So let's begin our today's session about what are the important aspects for nose as well as nasopharynx. Fine. So let me go to the first question. We have 10 questions lined up, and this first question comes up, and this is about a 3-year-old child who's brought with a midline swelling over the nasal dorsum. That means over the nasal dorsum, there is a midline swelling. Now, this is there since birth. The parents have got the child since birth, and they've noticed and it has progressively grown, this particular swelling. Mother complains that the swelling has progressively increased in size since the past 2 years. And now she has also noticed discharge coming out from the tip of the nose. So that means there is some kind of an opening over the tip of nose, and there is discharge coming out from the tip of nose. There is a swelling over the dorsum as well. Now I have attached a video showing the lesion on during examination. You need to tell me what is the likely diagnosis of this particular 2-year-old child. Chalo. So what exactly is the video? This is the video of that particular child, and what you can see over here, this is the child who has got a midline dorsum swelling. We can see something in the midline. It's not normal. And you can even see one particular thing, that over the tip of the nose, there is a kind of a pit. You can see that there's a kind of a pit or an opening that is present over the tip of nose. So what comes in your mind when you see a midline dorsum swelling over the nose with a pit over present at the center or the tip of the nose? What comes in your mind? So whenever, I'll tell you 3 important congenital disorders of nose which you need to remember as far as your NEET PG exams is concerned, because ये तीनों disorders अपने में important है as far as questions are concerned about embryological development of nose. Whenever you see midline swellings, there are 3 things that come in my mind. 3 चीजें मेरे दिमाग में आती हैं. And what are those 3 things? They could be any of these 3. That means either it could be number 1, or it could be number 2, or it could be this number 3. Now, what is number 1? What is this baby? This baby has a midline swelling over the dorsum, but there is no opening that is present over the tip of the nose. That is point 1. In the second, what we see here, we see only a possible swelling. Again, no visible opening, but the difference between this and this appears to be a little blue in color compared to this one. This appears to be more of skin color. And now the third swelling has got an opening or a pit. So what are these 3? All of them are important MCQs in your previous NEET PG exams. When I talk about number 1 swelling, what is that? That swelling is your encephalocele. So all those who have answered encephalocele, that video is not of encephalocele. ये जो swelling है, this is a nasal encephalocele. Now I'll tell you what are the differences between all 3 of them. ये जो second swelling है, this is called as a nasal glioma. And the third thing, wherever you see an opening or a pit, this is called as a nasal dermoid. This is called as nasal dermoid. So we are going to see each one of them कि इनकी क्या classifying characters होते हैं and how can you differentiate among all three of them. Now first let's take up this baby, right? Born with a swelling over the nasal dorsum. Now this swelling, if you see carefully, this swelling has got characteristics. That means this swelling appears to be bluish. So it is blue colored. So it is bluish. That is point number one, right? The second thing that you see over on an encephalocele is that this is a transilluminant swelling. If I place a torch over here, this will shine, right? So this is something which is a transilluminant swelling. This is a transilluminant swelling. Okay, fine. So this is bluish, this is transilluminant. Third thing, when I compress this swelling, this will be compressible. It will be compressible. ये compress हो जाएगी. So this is a compressible swelling. That is point number 3. Now, very important test we do to identify whether it is an encephalocele or not. And what is that test? That test is given the name as Furstenberg test. That is your question that has come in previous INI-CET exams. So you need to find out a word, and that word in your question will be Furstenberg test, positive or negative. If any swelling enlarges when the baby strains mean cough, cry, right? Agitates. That is the point of time the cerebrospinal fluid pressure becomes raised. जैसे ही बच्चा रोएगा, right? The CSF pressures get raised. Now, what is encephalocele? Encephalus means brain and its contents. So, when the meninges and the brain come out because of a defect in the midline, then that is called as encephalocele. So, obviously, this swelling has got an intracranial connection. So, any swelling where the baby cries or gets agitated and it increases in size, that test is called as Furstenberg test. क्यों? क्योंकि in Furstenberg test, whenever the baby cries, the intracranial pressure gets raised and the swelling of this nasal dorsum also increases. This is only positive for encephalocele. This is only possible for encephalocele. Okay, fine. Now comes your second swelling. अब ये second swelling देखो. Exactly what you saw over here, this is going to be negative here. That means it is non-bluish, it is non-transilluminant, this is hard, this is not as compressible as encephalocele, and this is Furstenberg test negative. यानी ये increase नहीं करती with the size when the baby is agitated or the baby is crying. There is no intracranial connection as it is in this second swelling. So this is a Furstenberg negative. Ulta, non-bluish, non-transilluminant, non-compressible. What is that? This is a nasal glioma. What do you understand by a nasal glioma? Glioma means that these are dysplastic glial cells which accumulate over the nasal dorsum. These are dysplastic cells, glial cells which accumulate over the nasal dorsum, and they don't usually have an intracranial connection. And that is called as nasal glioma. Exactly opposite to encephalocele will be a glioma. Ab aa jao third pe. Third means this. What is the characteristic feature? If you see any swelling over the nasal dorsum and there is also an opening with it. There is a swelling over the nasal dorsum with a central opening or a pit. What do you call that? This is a nasal dermoid. Dermoid ka matlab embryologically the ectodermal components get trapped at the nasal dorsum. So when the ectoderm gets trapped at the nasal dorsum, there is a pit that gets formed over at the dorsum of the nose. और ये जो pit होती है, this pit might also have hair in it. So the classifying feature of nasal dermoid is what? That the swelling will always have a pit. Always remember that. Right? So if you go back and see this particular child, what I showed you, this particular child had a swelling over the dorsum of the nose. अब कैसे पता चलेगा ये encephalocele है कि नहीं? The only thing that we did was that whenever the child is crying, see the child is crying, there won't be sufficient increase in the size of the swelling. When the child will cry, there won't be any kind of increase in size of the swelling. See, the child is crying. I'm examining the child will cry, the child started crying. There is no sufficient increase, the swelling is as it is. And the second is I notice there is an indentation on the tip. So what is this? The answer would become nasal dermoid. That is what you need to identify among all the three. Encephalocele mein, there would have been no pit, there would have been only Furstenberg test positive. That is what exactly the whole identifying feature is. Glioma mein, non-transilluminant, Furstenberg test negative, non-bluish, it is hard to touch, does not have any kind of a connection. That is a glioma. Okay, fine. So this answer becomes what? The answer to this question becomes nasal dermoid cyst. Right? The answer iska kya ho jayega? The answer would become nasal dermoid cyst. Right? So this is how we identify, yahi aapko pata hona chahiye, among the three midline dorsum swellings, that would be important that would be given to you, and these are the important ones that will have those kind of characteristic identifying features. ठीक है, फाइन. तो चलो, तो ये हमने कर लिया about the first and foremost question about what will you see over in all the three cases of congenital swellings over the nose. Now let me come to the next question, and the next question is question number 2. So now there is an attached video that I'm going to show of an endoscopic examination of the nasopharynx. So I'm going to do a diagnostic nasal endoscopy of a patient, and this basically is a normal endoscopy what I'm going to show you, right? Because many of the times they आपको pictures देते हैं, and in that endoscopy they ask you to identify what is this scene, right? So I'm going to show you an endoscopy of the nasopharynx, and I'll mark a specific area with my pen. What I'm trying to ask is, which of the following is the most likely diagnosis arising from the marked site? So whatever I mark, you need to tell me what is that area, and the second is what diagnosis comes out from that area. So what I'm going to do is, first I'm going to show you the video, and then I'm going to mark it, I'm going to pause, and I'm going to mark. So see, this is your nasal endoscopy that I'm doing. I'm passing the endoscope along the floor of the nose just to get into the nasopharynx. Okay. This is the right nostril. I'm going behind the right nostril is tarike se. And when I go back, I enter inside the nasopharynx. So this is the right-sided nasopharynx. This is the right side part of the nasopharynx. I'm telling the patient to swallow, and I am going to mark a particular structure over here, that what exactly you are seeing and which pathology arises from this area. Just a minute. What pathology arises from this area? What pathology arises from this area marked? What is this area? You need to first identify. So this is what you are seeing is the nasopharynx. What they have asked in previous questions of NEET PG is, उन्होंने ये mark किया है, and they have asked what is this. So first let us see what do you see over in the nasopharynx, and what exactly are the classifying features over here. Now the same thing what you are seeing over here, I'm going to draw. So this is what you are seeing inside the nasopharynx. On both of the sides of the nasopharynx, there is an opening, and this is called as eustachian tube opening, right? Okay. Very nice. People have already started to answer. Very good. Chalo. So this is your eustachian tube opening. The bulge present above the eustachian tube is called as what? The bulge present above the eustachian tube, this is called as torus tubarius. This is called torus tubarius. This is basically the cartilaginous bulge of the eustachian tube just above the opening, right? Now, there is a three-dimensional fossa which is collapsed that is present behind the torus tubarius. There is a three-dimensional fossa which is present collapsed behind the torus tubarius, and this is called as fossa of Rosenmüller. This is called fossa of Rosenmüller, right? So what you're seeing over here, see this, can you see this slit-like opening here? Very nice. This is what? This is your eustachian tube opening. Can you see a bulge over here present above the eustachian tube opening? This is what? This is your torus tubarius. And behind the torus, if I mark anything behind the torus, that is a collapsed fossa which is three-dimensional. You can't see it because it does not open normally. And this fossa is called as fossa of Rosenmüller. Now, my question was what arises, and everybody has already answered. That's quite correct. That the most common pathology that arises from the fossa of Rosenmüller is what? It is nasopharyngeal carcinoma. Multiple times asked question. What is the site of origin of NPC? It is fossa of Rosenmüller. It's a very three-dimensional fossa, collapsed fossa, और बिल्कुल पीछे होता है, behind the torus. Okay, fine. So this finishes about what exactly you see. I'm just going to play it again for you. So during this examination, if you see carefully, what I'm going to do, whenever we do any kind of endoscopies, we always tell the patient to swallow. Soft palate is below, right? So we always tell the patient to swallow. See, the patient is swallowing. As soon as the patient swallows, eustachian tube opens. Whenever the patient swallows, eustachian tube opens. Correct? So this is how we examine the nasopharynx, right? Now, what I'm going to do, I'm just going to show you a picture exactly of what I have done. I'm going to show you a picture of this exact case, and see, this is the picture of the right side nasopharynx. You have taken the scope along the floor of the nose behind, and what you see over here, this is what exactly you see. Right? What do you see on the lateral wall? What you're seeing is a slit-shaped opening. And what is this opening? This opening over there, that's your eustachian tube orifice, right? So what you see here as a slit-like opening, this is eustachian tube orifice. What is present above as a bulge of eustachian tube? Above the bulge, this bulge above the eustachian tube orifice, इसे कहते हैं torus tubarius. What is torus tubarius? This is basically the cartilaginous bulge of the eustachian tube orifice, right? When the eustachian tube opens, the cartilage folds and that produces a fold or basically a bulge over the eustachian tube. That's called as torus tubarius. And what is this collapsed fossa present behind? This collapsed fossa is your fossa of Rosenmüller. Extremely, extremely important. अगर वो video देंगे, नहीं देंगे तो ये this figure is very, very important and how we actually see these structures and how we make out कि where is exactly the site of origin of this, right? तो ये हमें नहीं भूलना है. This is what we need to remember. Now see, I'll tell you very classical features. अगर उन्होंने ये type की कोई cavity दिखाई and if they make any kind of mass like this over, तो अगर इसमें कोई भी mass आ गया, that mass is a nasopharyngeal mass. Now always see the age of the patient when they give you a question. If they are giving you a nasopharyngeal pathology या फिर mass, and they have asked you that mass is in a 7 or 8 year old child, the answer would be adenoid. 7 years में वही होता है. If they tell you there is a nasopharyngeal mass in an 18-year-old boy that has epistaxis, the answer will become JNA, juvenile angiofibroma. If they tell you there is a nasopharyngeal mass and the age of the patient is 55 years, likely the diagnosis is nasopharyngeal carcinoma. So don't ever get confused among pathologies. Adenoids can never be seen at 55, JNA can never be seen at 55. NPC can be the only thing that can be seen at 55 or 60 years of age. So please go according to the age groups when it comes to nasopharyngeal pathologies. कभी भी nasopharynx का video दिखाया, see the age what they are asking. 7 to 8 year old, nasal obstruction, snoring, mouth breathing, answer is adenoid. Any patient 18, 19 year old, nasal obstruction and epistaxis, JNA. And if they tell you 55 year old man, he has come with painless cervical lymphadenopathy, mass in the nasopharynx, they are showing a video, answer is nasopharyngeal carcinoma. That's how you differentiate accordingly, according to age groups. Okay, fine, chalo. So what will be the answer? Most of you have already given this answer. The answer to this particular question will be straightforward and it will be nasopharyngeal carcinoma without a doubt. And that's what is the mark site. That site is fossa of Rosenmüller. Site is fossa of Rosenmüller. So this finishes about the two major MCQs that have been asked over multiple times. Now we move on to the third MCQ. Let's make it a little more tougher and let's go on to the third MCQ of today. And this is about a 4-year-old child, not a very age-old child. This is a 4-year-old child, again a young child, and now they have come with persistent nasal obstruction, chronic nasal discharge, and difficulty breathing through one nostril since birth. Yani the baby was born normally, but since birth the child is having one side is blocked, they can't breathe properly, right? And at the same time, they have chronic nasal discharge coming from one side of the nostril. Okay, fine. Now, diagnostic nasal endoscopy shows partial occlusion of the posterior choana of the nose. What is the most important diagnosis when you can see it, right? Is it adenoid? Is it choanal atresia? Is it congenital pyriform aperture stenosis? Is it antrochoanal polyp? अब पहले video देख लेते हैं. Then we are going to see what is this pathology. So again, I'm going to take an endoscope, right? Again, this is the nostril. We are entering inside the nostril, and what we see inside is this kind of a picture. Again, this is the right side. Right? I'm standing like this. This is the right side of me. This is the turbinate, inferior turbinate. In your first pass of diagnostic nasal endoscopy, we pass the scope along the floor of the nose and what do you see over here? Now see, do you see the normal nasopharynx that I showed you right now? Do you see that whole nasopharynx here? क्या दिख रहा है यहाँ पे? Answer नहीं है. You can't see the whole of nasopharynx. You see something is blocking the nasopharynx here. There is a kind of a wall behind your posterior part of the nasal cavity. You can't see the nasopharynx. You can see partially, but you can't see it completely. Right? So what is this? What is the most common congenital anomaly of the nose? It is choanal atresia. Correct. So atresia का मतलब क्या होता है? That your nasal posterior choana is not open. It is closed, either completely closed या partially closed. Now somebody is saying stenosis. Stenosis is not the right answer. Right? This is called as choanal atresia. They will not give you congenital pyriform stenosis, always remember that. Right? This is something which is the posterior choana is not completely formed. It is not open. That means there is a block. Now this block can be pura, it could be complete or it could be partial. Now see this. Can you see this slit-like opening? ये eustachian tube दिख रहा है? Can you see eustachian tube के आगे कुछ भी नहीं है? It's completely blocked. You can see a small hole over here. So this is what? This is a partial choanal atresia. अगर ये पूरा होता, then it would have been a complete choanal atresia, right? So the trick was that this is partial occlusion. So choanal atresia में जरूरी नहीं होता. अब now let me show you. In order to get your confusion out, let me show you if you get a complete occlusion, how will it look like? See, दिस इज कंप्लीट ऑक्लूजन. ये देखो पूरी तरीके से हमारा पोस्टीरियर ख्वाना बंद हो गया. दिस posterior khana is open. You can see the nasopharynx through this side, but you can't see it from this side. So what is this? This is complete occlusion of posterior khana. Correct? और वहां पे मैंने क्या दिखाया? There I showed you a partial occlusion of posterior khana. But problem क्या है? This baby obviously when the baby is breathing, that particular point of time वो एक nostril से ज्यादा सांस लेता है, एक से कम सांस लेता है. So obviously what exactly is the problem? That at least one nostril of the baby is open. The other nostril is closed. Now remember one thing. When children are born, newborns are obligate nasal breathers. Newborns cannot open their mouth and breathe. And the reason is why? The reason is because their larynx is very high at the level of C2, C3. So, अगर वो larynx उनका इतना ऊपर है and if they open their mouth, the larynx gets shut. That's why all newborns are obligate nasal breathers. वो सिर्फ नाक से जानते हैं सांस लेना. So when a child gets born with atresia, कभी भी बच्चा born होगा with atresia, atresia is of two types. First type is called unilateral and the second type is called bilateral. This is on the basis of laterality. And the second thing is atresia could be either partial or it could be complete. It could be complete or it could be partial. Obviously partial is better than complete, right? Because complete में तो कोई भी जगह नहीं है सांस लेने की. So what is better, unilateral or bilateral? Obviously unilateral is better. So most of the cases with unilateral choanal atresia, they go unnoticed. They are asymptomatic since birth. क्यों? क्योंकि at least the baby is breathing from one nostril. One nostril is closed from behind, doesn't matter. So what will they present you with? They will present with nasal obstruction when they grow older. That is why when the child's history was given to you, the child's history was what? That this child was having an age of approximately 4 years. The child was asymptomatic all this while. But उसने देखा क्या मदर ने देखा कि one nostril, always there is discharge coming out. Now why the discharge comes out? Because the discharge cannot flow back. And that is why the discharge keeps coming out from the anterior part of the nostril, and that is how we came to a conclusion कि ये choanal atresia unilateral है, not bilateral. Now, the most important point, unilateral atresias have only these things in common. They will come with nasal obstruction, they will come with chronic nasal discharge, they will have difficulty in breathing from one nostril. But what about bilateral atresia? Bilateral atresia 4 साल के बच्चे में नहीं दिखता. Because bilateral is a situation जहां दोनों nostrils are closed from behind. So in that case, what will happen? In bilateral atresias, children will have cyanosis since birth. They are not breathing at all. So they will have cyanosis since birth. And what is that called as? Bilateral atresia has a cyanosis which is called as cyclical cyanosis. Bilateral atresia, if this whole diagnosis would have been around cyclical cyanosis, the answer would have been bilateral. और cyclical cyanosis का मतलब क्या होता है? I told you that when the newborns are born, they are obligate nasal breathers. So when they are obligate nasal breathers, so क्या होते हैं? Their both nostrils are closed from behind in bilateral atresia. The problem will be what? जैसे ही वो the moment the baby gets born, they will get cyanosed. अब वो cyanosed होगा तो बच्चा क्या करेगा? What will the child do? The child will get agitated. And when the child will get agitated, they will start crying. This is how you cry, right? You suddenly gasp for breath. And when you take in breath, you oxygenate. So these children, when they cry, they get oxygenated. And because they get oxygenated, the cyanosis gets reversed. So we always say in Hindi, bachcha rota hai, bachcha sota hai. That means the child will get cyanosed, cry, then again, the child's cyanosis will be reversed. That's the exact point what atresia happens, right? In bilateral atresias. Now the major problem that occurs is what? When a child is born with unilateral choanal atresia, जो मैंने आपको दिखाया, the only problem is nasal obstruction with chronic nasal discharge. And why is nasal discharge? Because the nasal discharge cannot go back. जो भी हमारे sinus से discharge आता है, that goes into your nasopharynx down into your throat. But here the child cannot take the discharge back. That's why it's coming out. So what happens when a child is born with bilateral atresia? In a bilateral atresia case, again your NEET PG question is this particular IBQ. In a bilateral atresia case, what is your major problem? The child is cyanosed since birth. When the child is cyanosed, they cannot know how to open their mouth and breathe because their larynx is very high. So what are you going to do? You need to open their mouth. And in order to open their mouth, what you are going to do? You place this kind of a nipple. And this nipple is placed in bilateral atresia babies who are cyanosed just to buy some time. और इसे क्या बोलते हैं? We call this as McGovern's nipple. Very correct. Many of you have answered this question. So this is called McGovern's nipple. Normally what happens? This is your bottle nipple. Correct? Now bottle nipple में हम लोग क्या करते हैं? We cut the end of the bottle nipple and we tie this with 2 threads around the occiput of the child. Now when we tie it around the occiput of the child, what will happen? The child's mouth will remain open no matter what. If the child's mouth is open, the child is at least breathing. Second is we can even use this for feeding. So two things can help out. This is only given in those children who have bilateral atresias. We call this as McGovern's nipple. Very, very important. Very important MCQ. Right? And that is only given for bilateral atresia. अब मैं आपसे एक और question पूछता हूँ. Another of your questions of choanal atresia. What is one drug used in pregnancy that can cause choanal atresia? And what is one syndrome that is there that can form choanal atresia? So two important MCQs from choanal atresia. What is one drug used in pregnancy can cause choanal atresia? One maternal drug taken during pregnancy that can cause choanal atresia is called methimazole. So methimazole consumption during pregnancy can lead to choanal atresia. Again, an important MCQ asked previously. Methimazole consumption can cause choanal atresia since birth. Yeah, important. Now comes another important thing. What is one syndrome which is associated with the formation of choanal atresia? One syndrome which is associated with the formation of choanal atresia is charge syndrome. Charge syndrome. Okay. Now, what is charge? C stands for coloboma of iris. Coloboma ka matlab keyhole iris. The iris doesn't form. It's a keyhole iris. H stands for heart defects. So basically, these babies are born with conotruncal anomalies. Conotruncal anomalies, truncus arteriosus as well as conus elasticus is not well formed, right? So this is conotruncal anomalies of the heart. A stands for atresia of the nose. R stands for retarded growth. These have retarded growth. G stands for genitourinary anomalies. So they are born with maldeveloped kidneys. So they have renal aplasia. So they have genitourinary anomalies, and E stands for ear anomalies. This is one syndrome which is closely associated with congenital choanal atresia. Okay, now comes important another question. How will you treat choanal atresia? So the only treatment of choanal atresia is we need to do an operation straight away. We need to open up the child, right? So we need to open up the nostrils so that the child can breathe, be it unilateral or be it bilateral. Now, the most important point is what we need to do or what operation we need to do and what we need to apply. So the thing is, whenever you put a blade over the body heals back. If you put a blade over here, fibroblast वापस आ जाएंगे, it will close the wound again. So what I need to do is, if I excise this particular area out, अगर मैंने इसे खोल दिया, if I excise it out, the problem is what? This will heal back again and close. So what is one thing that I want to do during the operative procedure? I will apply an ointment. And what ointment will I apply in order to prevent refibrosis? ये भी एक question है. So that is mitomycin C. Mitomycin C is an antifibroblastic agent. We are going to cut open this particular atresia, and when we cut open the atresia, we are going to apply this ointment over the edges called as mitomycin C, which is an antifibroblastic agent, and it will prevent refibrosis. Very nice. Everybody is already answering. So we do a laser excision. Usually we use a laser, and then after that, we cover the whole area up with mitomycin C. That's quite correct. Fine? Chalo. So this finishes about a very, very important disorder, that is choanal atresia, that is seen since birth, right? And the baby usually comes with that. Fine. Now let's go on to the next question, and we have covered the important questions from this particular area. Now this is about another 16-year-old boy, and this particular adolescent male comes with recurrent sneezing, watery rhinorrhea, nasal itching, and nasal obstruction. Okay, important symptoms, especially after exposure to dust. The video attached has multiple characteristic findings consistent with the condition. Okay, so I'm going to show you a video, and I'm going to show you what exactly are the findings that I can see over this child. Okay, and is it chronic sinusitis with nasal polyps? Is it allergic rhinitis? Is it acute viral rhinitis, or is it atrophic rhinitis? This is what we need to figure out. Already people have started answering. Okay, fine, good. So first, let me show you the video. So this is about a 16-year-old boy who has come to me with primary 4 symptoms, that is rhinorrhea, itching in the nose, block, and sneezing, right? Now, what do I see over here? And here I want to identify certain important signs which you see in this condition. Now, first you see the video. What I'm going to do is I'm going to demonstrate certain signs, and then I'm going to show you what exactly these signs are all about, right? So I'm showing certain important signs which are present over this particular young boy, right? Now, what are these signs that I'm trying to show you here? These signs are of a disorder called as allergic rhinitis, right? So this is an allergic rhinitis case where you can see certain important facial signs. So सबसे पहले we are going to go one by one into all the signs that you see. Now see, this is the tip of the nose. Now what happens, what I'm doing over here, this is called as an allergic salute. The first thing, it's also called as salam sign, also called as allergic salute. Allergic salute क्या होता है? Whenever any person has got rhinorrhea, what is the first thing that you do? You keep doing like this, right? So this is called as allergic salute. First important sign of allergic rhinitis. अब problem क्या आती है? If you keep doing this allergic salute, there will be a line that will form over the nasal dorsum. Right? There will be a prominent line that will form over the nasal dorsum. And if a prominent line forms over the nasal dorsum, let's say this is the nose, right? So there will be a nasal dorsum pe line, which is very prominent over this guy also. If you see here, this line has become very, very prominent. This line is called as a dorsal nasal pleat. This is called as dorsal nasal pleat. Also called as Darier's line. इसे हम लोग Darier's line भी कहते हैं. Also called as dorsal nasal pleat. Okay? Now, what is the next thing that you will see over in this particular boy, right? The next thing that you will see over in this boy is that because of the constant salute and this dorsal nasal pleat, what is the next thing that will happen is, if you see, he has got these kind of dark circles present below his eyes. Can you see that? What are these called as? So see, this is the Darier's line, right? Now what do you see? These are quite big dark circles. What are these dark circles called as? We call these dark circles as allergic shiner. Allergic shiner. Now, what do you understand by an allergic shiner? If you don't sleep well, especially doctors don't sleep well, except for if you are a dermatologist, definitely you can hide off those kind of dark circles which all doctors have. But if you are not, definitely they will be seen quite prominently. So all doctors have got these kind of dark circles. Right? And what exactly are these dark circles? Let's talk about. Is it hyperpigmentation? क्या ये hyperpigmentation है that you are seeing over here? The answer is no. This is not hyperpigmentation. This is not hyperpigmentation. And why is that hyperpigmentation not there? Because I'll tell you. See, this is not melanin. People keep selling these kind of beauty products and they tell to put creams over here and the dark circles will grow away. This is not the right thing. These dark circles come in everyone who are basically having disturbed sleep. And why is that? It's because of facial venous congestion. ये जो dark circles है ना, they are all these congested veins which are shining through your face. Now below your eyes, this is the skin which has got least amount of fat. इसमें बिल्कुल कम fat होता है. So the veins are extremely visible through this area. Now the most important thing is कि जितनी हमारी facial veins होती हैं, all our facial veins are valveless. They do not have valves. So what happens is, when you move your face, your facial veins get squeezed with the blood. And when you relax your face, they drain out. When you move your face, they get squeezed. When you relax your face, they drain out into the internal jugular vein. What happens when you don't sleep well? Or if you have allergy, you keep squeezing your eyes, you keep rubbing your nose, you are having a lot of congestion over the facial venous area. And because this is a very thin skin, your facial veins will shine out. And that is why, because your facial veins are shining out, they are congested. That's why we always say take a beauty sleep or do a spa. आपकी सारी के सारी muscle relax हो जाती हैं, all your veins get drained off, and that is why you get good amount of glow when you have a very, very good sleep. Definitely after NEET PG you will get. But this is called as an allergic shiner. Okay, this is what is facial venous congestion. अब आ जाओ एक और important चीज पे. Can you see this prominent infraorbital line? What is this prominent infraorbital line? This prominent infraorbital line, इसे हम लोग कहते हैं Denny-Morgan fold. We call this line as Denny-Morgan fold. We call this line as Denny-Morgan fold. So what is Denny-Morgan crease or Denny-Morgan fold? This is basically the eyelid muscles. They undergo spasm because of constant rubbing. The eyelid muscle undergoes spasm. It's the Muller's muscle which undergoes spasm, और इसकी वजह से this particular fold gets formed. So what are the important 4 signs of allergic rhinitis, right? The 4 signs of allergic rhinitis are: number 1, that is the allergic salute. Number 2, that is Darier's line. Number 3, it's allergic shiner. And number 4, Denny-Morgan fold. I am shining? Okay, that's, I think, because of the camera. That's the camera effect, not my original face. Okay, great. Chalo. So this finishes about 4 important signs of allergic rhinitis. अगर मैं आपसे पूछूं what will be the endoscopic finding? The endoscopic finding of allergic rhinitis is mulberry turbinates. You see mulberry turbinates. Your turbinates will be big, boggy and mulberry-like. This is an endoscopic finding of allergic rhinitis. Okay, fine. Chale. So this finishes about what you see over in allergic rhinitis patients. So what I have asked you here, most of you already answered it right, that this is a case of allergic rhinitis with the visible signs that we have seen over, and whatever holds importance, हमने सब देख लिया. ठीक है? This finishes our question number 4. Now let's move on to question number 5. Okay, fine. Now, in question number 5, I have got a 35-year-old man for you with recurrent episodes of unilateral anterior epistaxis. That means the patient has come with epistaxis and it is unilateral. Okay. Now, over the past 6 months, now always, students get hurried. Students always see कि epistaxis है तो JNA होगा. 35-year-old can't have JNA. Can't have JNA, right? So, this is something which is basically having recurrent episodes of unilateral anterior epistaxis over the past 6 months, right? Now, he denies any history of trauma, anticoagulant use, or bleeding disorders. That means there is no other history that is significant for epistaxis. The attached nasal endoscopy video demonstrates a sharp bony projection arising from the nasal septum. So let me first show you what exactly is this video all about, and then you will be able to see. So this is again a diagnostic nasal endoscopy. This is again the nostril of the patient, and what you are seeing over here, can you see this sharp deviation of the nasal septum, which is going up till the turbinate? So this is my inferior turbinate and this is my septum. Can you see that sharp bend? Again, if you want to see, again, see how sharp the septum is. So anywhere if the septum is sharp, what answer should come in your mind? So this is your middle turbinate. This is your inferior turbinate over here. And you see the septum has got a sharp bend. Correct? So what it becomes? Yes, very right. All of you are right. Whenever you see any kind of a case where you have got a sharp bend from the nose, what is this? This is not a polyp. This is a spur. Polyps are swellings. So see, there's a nasal septum. Ko dekho kitna sharp ye bent hai. This is what? This is called as septal spur. This is a septal spur. So what exactly is a septal spur? Septal spur means what? That when your nose septum is having a sharp bony cartilaginous junction which is bent. A sharp bent at the bony cartilaginous junction of the septum is called as nasal spur. Okay? Up two important questions related to spur. First question is, what is the most common cause of epistaxis in DNS? The most common cause of epistaxis in DNS is nasal spur. Why? Because the spur is very, very sharp. So whenever the patient sneezes or blows the nose, it will start to bleed. So ये सबसे common DNS होता है which causes epistaxis. That's point number 1. First question. Second question that comes from nasal spur is that if this spur is impinging over the middle turbinate, yani ki you have got your middle turbinate over here. Now, if you have got an inferior turbinate over here, if this turbinate is getting touched by the spur, what is going to be the feature in the patient? So this middle turbinate contains a very important nerve. ये important question है, पहले भी आया है. This important middle turbinate contains an important nerve, and the nerve present inside the middle turbinate is anterior ethmoidal nerve. तो अगर कोई भी बहुत sharp spur होता है, what is going to happen? ये spur is going to impinge the middle turbinate. ये middle turbinate को छुएगा, right? And when it goes and impinges the middle turbinate, कौन सी nerve involve होगी? Anterior ethmoidal nerve. And if anterior ethmoidal nerve gets irritated, what will the patient have? So usually patients with spur who have got hemifacial pain and headache. Patient will come with this whole area will pain and this headache will come. So if the patient turns up with hemifacial pain and headache, this particular pathology is given the name as Sludder's neuralgia. इसे कहते हैं Sludder's neuralgia. Again, an important question. What is Sludder's neuralgia? Sludder's neuralgia is basically anterior ethmoidal nerve irritation that happens because of a sharp spur which impinges over the middle turbinate. This is called as Sludder's neuralgia. तो ये दो important questions आ गए spur से. Right? So always remember, this is a very, very important thing that is related with spur related questions. Right? Okay. अब मेरा एक important question है. Let's say patient has got unilateral nasal obstruction. इस तरफ nasal obstruction है. But the patient comes to you with not left-sided obstruction. ये left side है. Patient says, I have got right side nasal obstruction. That means it's a paradox. Patient comes to you with DNS. DNS is on the left side, but patient has got right-sided nasal obstruction. What is the reason for right-sided nasal obstruction? The answer is compensatory inferior turbinate hypertrophy. एक और MCQ. What happens is, because this DNS is on the opposite side, this nose is already utilized very less since birth for breathing. So what happens is, ये nostril बहुत utilize हो रही है for breathing. And if this nostril is utilized more and more for breathing, what is going to happen? There is going to be inferior turbinate ka hypertrophy this side. Why? Because this is overutilized. And anything in the body, if it is overutilized, it causes hypertrophy. So this leads to compensatory increase in size of the inferior turbinate of the opposite side. इसे क्या कहते हैं? We call this as paradoxical nasal obstruction. paradoxical nasal obstruction. What is that? It is because of the compensatory increase in the size of the inferior turbinate of the opposite side. ठीक है, फाइन. सो दिस इज समथिंग दैट इज वेरी वेरी इंपॉर्टेंट कि डीएनएस हो सकता है एक साइड पे हो, पर आपसे कहा हो कि ऑपोजिट साइड पे देयर इज ऑब्स्ट्रक्शन. आपका आंसर होगा द ऑपोजिट साइड कैन आल्सो हैव एन ऑब्स्ट्रक्शन. व्हाई? बिकॉज ऑफ अ पैराडॉक्सिकल नेजल ऑब्स्ट्रक्शन कॉज्ड ड्यू टू कॉम्पेंसेटरी इंफीरियर टर्मिनेट हाइपरट्रॉफी. दैट्स क्वाइट करेक्ट. फाइन. चलो, तो ये हो गए हमारे इंपॉर्टेंट क्वेश्चंस दैट आर रिलेटेड विद डीएनएस एंड what exactly they can ask you. So the answer to this question will become what? The answer to this question is straightforward, that it is going to be a septal spur. Okay, fine. It is a sharp bony projection of the nasal septum. Okay, fine. So we have done halfway. We have done 5 important MCQs of the nose. Now we move on to number 6, right? Chalo. So number 6 is about a 24-year-old man. देखो ज्यादातर इसी एज ग्रुप के लोग हैं. And this is about a progressive unilateral nasal obstruction. Again, the person has got unilateral nasal obstruction. Hyponasal speech. Hyponasal speech का मतलब जैसे कोई nose ने बंद कर दिया and somebody is talking to you. Snoring. And the patient has got occasional mucoid nasal discharge over the past 1 year. Medical therapy has provided minimal relief. The attached diagnostic nasal endoscopy video demonstrates the findings. Attached CT scan also has been given to you with the following findings. So I am talking about here about a 24-year-old boy. And this particular boy has come with unilateral nasal obstruction, nasal discharge, and hyponasal speech with snoring. And I'm going to show you a video what that boy has. I'll also going to show you what is the CT finding of that. फिर आपको मुझे बताना है कि इस 24-year-old में हुआ क्या. Is it AC polyp? Is it ethmoidal polyp? Is it inverted papilloma? Is it JNA? Let's see. First, let's go into the video of this 24-year-old boy. And let's see what exactly this boy has. So again, I'm going below the inferior turbinate along the floor of the nose, जैसे हमने पहले पढ़ा था, and I'm going, but I can't reach the nasopharynx. I see something. This is kind of a gray. It's glistening. It's globular. Can you see this gray glistening globular mass inside the nasal cavity? Now, can you tell me what can happen as a gray glistening globular mass, 3G, gray glistening globular mass inside the nasal cavity, 24-year-old boy, and the boy only has got features of nasal obstruction, hyponasal speech and discharge, occasional snoring. What is this mass present inside the nasal cavity? And what is your diagnosis? So now in order to again confirm कि diagnosis क्या है, I went ahead with a CT scan. मैंने CT scan कराया इस same person का and I got this kind of a finding. So this is a right-sided and there is something that I can see, something grayish coming out inside the nasal cavity. So people are already answering. Somebody is saying polyp, somebody is saying B. So most of you are saying antroconal polyp. So the answer is antroconal polyp. Absolutely right. This is antroconal polyp. Now let me first tell you what are the identifying features of this, right? How will you identify what is this case and how you're going to come to a diagnosis? So point 1 is, what is a polyp? First you need to understand what is a polyp, right? So let's say this is your nasal cavity, right? This is your septum. This is inferior turbinate, middle turbinate, inferior turbinate, and this is your maxillary sinus. ये हमारी maxillary sinus opening है, right? Now what exactly is the lining of your nasal cavity? The whole nasal cavity is lined by pseudostratified ciliated columnar epithelium. Whole of your lining of the nose is pseudostratified ciliated columnar epithelium. Right? Same lining हमारे sinus में भी होती है. Even our sinus has got the same lining of pseudostratified ciliated columnar epithelium. Correct? Now, what happens is, what do you understand by a polyp? Polyp means any mass which hops out. Any mass which hops out. ऐसे लगेगा ना कूद के बाहर आया है. It's hopping out. So if it is hopping out, what does a hop mean? Any mass in the nasal cavity which is hypertrophied, edematous, and prolapsed. So what exactly is a polyp? It is a hypertrophied, edematous, prolapsed mass inside the nasal cavity. और क्यों होता है ये? Under the influence of constant infections or allergies. So most commonly अगर मैं AC polyp की बात करूं, it happens because of recurrent infections. Ethmoidal polyps which are bilateral, multiple, they happen because of allergies. But AC polyps usually happen because of recurrent infections inside the sinuses. So what will happen? This infection will keep on stimulating this mucosa, and one day what will this mucosa do? This mucosa will become edematous, hypertrophied, and it will hop out and it will become a protruded mass inside the nasal cavity. Now because this arises from which sinus? Maxillary sinus. So this part is called as the antral part. Then it comes into what? One second. Just a second. Okay. Now, once it comes out into the nasal cavity, what is it called as? Inside the nasal cavity, this is called as the nasal part. And once it grows, तो ये कभी भी आगे grow नहीं करता, it always grows backwards to your posterior choana and nasopharynx. So that is why the posterior part is called as choanal part. So what are the three parts of antrochoanal polyp? It is antral part, nasal part and choanal part. And which sinus it is arising from? The only sinus which it arises from is the maxillary sinus. So all of them are questions. Antrochoanal polyp arises from maxillary sinus. What is the most common cause of antrochoanal polyp? It is infection. What are the parts of antrochoanal polyp? It is antral part, nasal part, choanal part. What is a polyp looking like? So polyps are always 3 G's. They are grey, they are glistening, and they are globular. Grey, glistening, globular mass. Jahan pe bhi grey, glistening, globular mass hai, it's polyp. Now always remember one point. AC polyps are usually in the younger lot. Ethmoidal polyps are always in the bilateral lot as well as elderly lot. That means any man, if they tell you with bilateral nasal obstruction and they are showing you multiple kind of these grey masses over in the bilateral cavities, answer would be what? That answer would be ethmoidal. But if they show you any kind of a picture or a video or an image of a unilateral nasal obstruction, one side there is a polyp, that answer would be nothing but antrochoanal polyp. Now comes another point. If I give you a CT scan, if you see this CT scan, anything on CT, white is bone, black is air, grey is soft tissue. Now, what is your normal sinus containing? Normal sinus is containing air. If you see, this is air and this is your maxillary sinus. This is your maxillary sinus. This has air. If you see in the center, this is your nasal septum. This is inferior turbinate. ये जो J shaped है, this is your middle turbinate, right? This is your orbit. Correct? Now, what you see over here, can you see air over in the sinus? No. You see there is something grey and that grey thing is filling the whole of your maxillary sinus and coming inside into the nasal cavity. Same kind of a thing you see over here. So what is this? This is an antrochoanal polyp. Now again, I'm going to tell you two important identifying features. If they give you similar kind of a CT scan, that means maxillary sinus is involved, mass is coming into the nasal cavity, and they tell you this mass bleeds, and they tell you this is a 50 or 40-year-old male, answer would be inverted papilloma. But if they tell you that this is a young boy who does not have any epistaxis, because antrochoanal polyp mein epistaxis is not the feature. This is your INI-CET question. They showed you a mass in the nasal cavity and this maxillary sinus once, and they asked you which among the following has got least chances of epistaxis and bony invasion, and answer was antrochoanal polyp. This is a PYQ. So always remember, if they show you any kind of a lateral nasal wall mass, maxillary sinus is involved, but this mass is bleeding, occasional epistaxis likhte hain, and they tell you that that is a 50 or 60-year-old man, answer is not AC polyp, because AC polyp is not seen at that age group. But if they tell you that this is a grey glistening globular mass occupying the maxillary sinus coming into the nasal cavity, sneezing, obstruction, hyponasal speech is the most common feature, then your answer would be antrochoanal polyp. Remember this is the DD behind, because antrochoanal and as well as inverted papilloma have same kind of features over on CT. Okay, inverted papilloma is an intermediate benign, it's an intermediate malignancy, right? It's a benign disorder which has got an intermediate malignancy. It's a vascular disease. Okay, fine. But polyps nahi hai. Polyps are never vascular. Polyps mein koi bony invasion nahi hota. They are very, very soft and subtle. So dekho, isme kya dikh raha hai? You're seeing a very smooth grey glistening globular mass without any kind of vascularity. So what is this? This is going to be a nasal polyp. See, grey glistening globular, 3 G's. So this answer would be AC polyp. Fine? Chalo. So ये हो गया हमारा what is AC polyp and how do you need to identify the important features to define कि ये AC polyp का question है and not inverted papilloma. Now, what exactly is here? The answer would become an antrochoanal polyp. Fine? Chalo. So ये हो गया हमारे important 6 questions. Now we are going to go into the number 7th question and we are going to see some other pathology now. And now we are going into question number 7 and this is about a 56-year-old man. Again, now this age matters over here. Again, the second point itself gives you the diagnosis clue. This is about a poorly controlled diabetes mellitus who is present with facial pain, diplopia. Now, eye features are also there. Periorbital swelling and numbness over the cheek since 4 days. That means it's an acute disease. Ye turant rapidly progressive hai and this whole area has been involved. Okay, fine. Now, the attached diagnostic nasal endoscopy video demonstrates the underlying pathology. So, first let's see what is the pathology and then let's take up the answer. और ये बहुत बार पुराना MCQ रहा है. recently, if you see INI-CET, this MCQ was 2 inside it. Out of the 10 questions of ENT, 2 questions were from this. So what is this? First, identify this particular disorder. So if I go inside the nasal cavity, you see I can't see any of this. I'm taking my suction inside just to see inside. The whole nasal cavity is completely destroyed. And can you see these kind of blackish colored crust inside the nasal cavity? Can you see these black colored crusts which are filled inside the nasal cavity? Right? Now you see, I'm taking my suction, I'm seeing, and there is a very thick blood-stained, foul-smelling discharge. I'm going to suction that out. You see that? Very thick, blood-stained, foul-smelling discharge coming out. There is intense destruction of the turbinates. There is intense, the whole nasal cavity seems to be completely destroyed ho chuki hai, right? I can't find out good amount of anatomy inside, right? It's all haphazard. It's all black. So jahan pe black necrotic tissue dikhe, what is that? It is mucormycosis, right? This is black fungus. This is mucormycosis. Extremely, extremely important for your INI-CET and NEET PG exams. So what is exactly this? The answer to this is that this diagnosis is definitely what? This diagnosis is mucormycosis. Now let me give you all the important MCQs of mucor so that you don't miss out. If I tell you what is mucormycosis, your answer should be it is containing black crust. Whenever you see black crust, it is mucormycosis, right? Now, always remember, mucormycosis does not have destruction locally. It spread karti hai to the surrounding structures. It even spreads to the brain, it spreads to the eye. So that is why this person also has facial pain and it's also having periorbital edema because it's spreading into the orbit as well. Correct? Now, the second question, what is the most common organism for mucormycosis? All are your PYQs. Most common organism is Rhizopus. So they belong to the family Mucorales. But if I ask you most common organism, again INI-CET PYQ, what is that? It is Rhizopus. Most common organism to cause mucormycosis. अब आते हैं third MCQ पे. Third important MCQ of this is, what is the most common predisposing factor? Most common predisposing factor is always uncontrolled diabetes mellitus. It very commonly happens in poorly controlled diabetes mellitus, and that is why I give you a diagnosis of diabetes only. So ये diabetes में सबसे commonly दिखता है, right? Because diabetes में free sugars होती हैं. When there is free sugars, definitely the fungus breeds on those sugars, right? Okay. Now what is the next important MCQ from this particular thing? What is the most important diagnostic investigation to prove it is mucormycosis? The most important diagnostic investigation of choice to prove it is mucormycosis is histopathological examination. So we always do a histopathological examination to prove कि ये mucormycosis ही है before we start the treatment. But yes, हम इसके लिए रुकते नहीं है because the HP report takes a long period of time. We start the empirical treatment as soon as possible because we don't have time, right? Because it is an angio-invasive fungus. ये angio-invasive fungus है, right? It invades the tissues by spreading and causing necrosis of the vessels. If I ask you, what is the contrast enhanced MRI radiological sign seen in mucormycosis? The answer is black turbinate sign. So your turbinates become black. So what is the most important radiological sign seen for mucormycosis? It is black turbinate sign. Okay, fine. Yes, immunosuppression definitely is the predisposition, but diabetes also is an immunosuppressive disorder. It's maybe immunosuppressed होता है patient. So this is among the most common. That's what I'm saying, right? Okay. Already one person has already answered. Correct, right? Now, if I ask you what is the most important treatment or management in such cases, the most important treatment and management in such cases is start the patient on liposomal amphotericin B and do an immediate surgical debridement. This is the most important drug, most effective drug against this. So this is liposomal amphotericin B. And now see what they asked in INI-CET this year. They asked ki, what among the following is drug not given in case of mucormycosis? And there were 4 options. First option was liposomal amphotericin B, second was posaconazole, third was ivasuconazole, and fourth was voriconazole. Now always remember, ये जो drug है, this is a primary start point where we give the patient liposomal amphotericin B. Now always remember that after we complete the liposomal amphotericin B patient treatment, we switch the patient to oral antifungals. After this IV liposomal amphotericin B is given, we switch the patient for long-term treatment for 3 to 4 months on oral drugs. And oral drugs that are under trial and they are found to be very good against mucor is posaconazole and ivasuconazole. AIIMS had one of the biggest trials that happened in the country, and they were concentrating on these two drugs. So it's basically posaconazole and ivasuconazole. Voriconazole is not given over in such cases. And why voriconazole is not given? Because voriconazole is a drug of choice for aspergillus. Right? It's aspergillus. Very nice. People are already answering it's for aspergillosis. So this is majorly for mucor. Okay? When they ask you allergic fungal sinusitis associated with aspergillosis, that's something where you give voriconazole. Usme ye nahi denge. These are the most important ones, right? If they ask you what is the category of these hyphae, so they are broad aseptate 90-degree branching hyphae, right? जो hyphae होते हैं mucor के, they are broad, they are aseptate and they branch at 90 degree. So see the 90 word. They are always 90-degree branching. These are all the important questions that are revolving around mucormycosis. Okay, fine. So what will be the answer here? It will be intravenous liposomal amphotericin B with emergent surgical debridement. This is what you need to do over in this patient. Okay, so this covers. So see, that's what I say. If VBQ padne ka matlab nahi hai ki you see the video and you answer. It's about you understand a lot of things around which can come as potential questions. And I'm very, very confident about ki kuch cheezein ENT mein nahi badlengi. They will ask laryngeal carcinomas, they will ask mucormycosis, the allergic fungal sinusitis. They are going to always go into one or the other things about laryngeal paralysis. Wo set questions that they keep asking again and again. So you just need to smartly focus on what they ask. Then go into other stuff which when you get time. But don't miss out on the important topics that you should do. Right? Chaliye. So this finishes about question number 7. And now we move on to question number 8. Right? So this is mucor. I hope you guys have seen all the intense black necrotic destruction, what I showed you. Chalo. Now we move on to question number 8. And this is about a 30-year-old female. Again, a young female. And she has got unilateral nasal obstruction since 5 years. Occasional epistaxis is the feature now. Sometimes occasional epistaxis. Now she had a history of foreign body inside the mist, inside the nose, mist imbli seed. So the imbli, you know, right? Imbli, tamarind. So she had got a tamarind seed or an imbli seed 10 years back, for which she didn't seek any help. So this is what about a young female who has come to you. She said कि मेरे, in my nose there was some tamarind seed या कोई इमली की seed थी, वो miss out हो गई, मैंने कभी दिखाया ही नहीं. For 10 years I left that and I was okay. I thought the imbli seed has gone away on its own. But what has happened now? Now she comes after 10 years with unilateral nasal obstruction with kind of a very occasional epistaxis. So what exactly is this? Most of you have already started answering. So what exactly is this? So you see this. When I enter the endoscope inside the nostril, you see this kind of a stone. See this? It's like a stone. It's not a lesion. You see, this is a stone. It's a calcareous mass. And what is this calcareous mass? This is something which is like stony hard. You see, this is the middle turbinate. What I can see behind, this is not reaching the middle turbinate, but I can see something like a stony mass over here. So now what is this? Missed foreign body 10 years back. Now it has become a complication. What is the stony mass all about? This is rhinolith. Very nice. All of you are right. So this is rhinolith. What is a rhinolith? Rhinos means nose, lithos means stone. This is inferior turbinate, this is middle turbinate, this is middle turbinate, this is inferior turbinate. Now, let's say this lady had got an imbli seed which was like this. She had missed out and she never removed it. Very commonly seen in the lower socioeconomic strata in village areas. People don't bother about it. They say that will go on its own. Now what happened was this imbli seed, it caused a kind of a reaction around, right? So what happened was it started forming granulation tissue around it. So obviously there was formation of granulation tissue around it. Now what happened if there is any foreign body which is missed out for a long period of time, what happens is as a reaction, body starts to lay down calcium and magnesium salts around it. इसके अराउंड बहुत सारे कैल्शियम एंड मैग्नीशियम सॉल्ट्स आ जाते हैं एंड व्हेन कैल्शियम एंड मैग्नीशियम सॉल्ट्स आर लेड डाउन around a foreign body, it becomes a stone-like mass. These are calcium and magnesium salts which are laid down around the foreign body and it forms a stone-like hard mass. And what do we call this? We call this mass as rhinolith. This is called as rhinolith. Now, what do you do with the rhinolith? There is no medical line of management for rhinolith. So, what you are going to do? You are going to remove the rhinolith and we do something called as piecemeal removal. Piecemeal removal means what? We break it into multiple pieces because it is stony hard. And we are going to remove it piece. Now, the most important question that comes is, what is the complication that rhinolith, if it is not removed, can cause? So, if there is a rhinolith, it will lead to septal perforation. It will keep causing septal area to get eroded and it will lead to septal perforation, which is very, very commonly seen in such cases. Okay, so untreated rhinolith can lead to septal perforation. Fine? Chalo. So, this becomes rhinolith, straightforward question. And now you have seen also how a rhinolith looks like. Please pay attention to the histories. See, histories are extremely important to guide you ki kaun si diagnosis hai, right? So this answer would become rhinolith. Why not AC polyp? Because AC polyps will be grey glistening globular masses, right? That's as I've showed you. Why not inverted papilloma? Inverted papilloma is a fleshy mass, unilateral nasal cavity obstruction plus bleeding. Not in 30-year-olds, it will be at 50, 60. Why not esthesioneuroblastoma? Esthesioneuroblastoma is a basic tumor which is seen in adolescents. It is from the olfactory neurons. So ये बहुत superior masses होते हैं. And this is there in very, very young boys or very young girls, right? So this is something which is called as rhinolith. Fine? Chaliye. So this is what exactly is your answer to question number 8. Now let's move on to question number 9. Now this is about a young child. Now see what I told you. Always concentrate in nose about the age. 7-year-old child with long-standing history of nasal obstruction, mouth breathing, snoring and recurrent episodes of sleep disturbance. Examination reveals a hyponasal voice and features suggestive of chronic nasopharyngeal obstruction. So first let me show you what exactly is the video and then let's go on to discuss about what exactly is the diagnosis. See, this is your inferior turbinate. I'm taking my endoscope below the inferior turbinate along the floor of the nose to reach the nasopharynx. And when I reach the nasopharynx, I see what? I see there is a kind of a mass. Can you see this mass inside the nasopharynx? You can't see the complete nasopharynx. See, soft palate is getting elevated. It's getting elevated, but you see half or 50 or 60% of your nasopharynx is getting occluded. What is this mass present over in the nasopharynx? Now, again, I told you the same thing. If I tell you this nasopharyngeal mass is there in a 55-year-old, what is your answer? Answer is NPC. Nasopharyngeal carcinoma mein, NPC mein, this will be a mass which will be seen at 50 to 60-year-olds. And the most common thing is this mass will be associated with painless cervical lymphadenopathy. Then it's NPC. Agar main bolta this mass is there in a 19-year-old boy who has recurrent epistaxis, answer would have been juvenile angiofibroma. But agar main ye bol raha hu that this mass is there in a 7-year-old child, so obviously answer kya hoga? There will be adenoids. Adenoid is the most common nasopharyngeal pathology, a nasopharyngeal mass which is seen over in the nasopharynx, right? So see, this is a nasopharyngeal mass which you see over inside the nasopharynx, and this is how an adenoid looks like. It decreases the vertical height of the nasopharynx, and see now almost 60-70% of the nasopharynx is obstructed. Now what will happen? Because this child is not breathing properly from the nose, right? So what is going to happen? This child will keep breathing from the mouth. Now when this child will keep breathing from the mouth, then what will happen? Let's take up important MCQ. So let's say this is the child, big, long face of the child, right? So this is a long face of the child. And why long face? Because the child has been opening his mouth and breathing because he can't breathe from the nose. Nasopharynx is blocked. So he's breathing. So what has happened? The mandible has become elongated. So they have got elongated mandible. And because they have got elongated mandibles, their chin becomes very, very small. Because unka muh khula hua hai. So now their chin has become very small. So they have got a small chin. They've got a small chin, right? Now, what is the second thing that will happen in this child? The second thing is this child is not sleeping well. This child is not breathing well. So what is going to happen? When this child is going to come to you, the child will be extremely dull. Children are very, very inquisitive creatures. But if they don't sleep well, what will happen? The child will be like this and it will come to you with an open mouth. So what is that child? The child will be very, very extremely dull. The child will be extremely dull. The child will have a dull expression or an expressionless face. They will not be having very inquisitive nature inside, right? So they will be very, very dull child. Now what will happen? The next thing, the child is not sleeping well. So the child is having facial venous congestion, because of which the child is having big, big dark circles. The child has got dark circles, right? Because the child is not sleeping well. Simple. Now the next thing, is the child using his nose to breathe? No. So if the nose is not getting utilized to breathe, the nose will become very, very small. Ala atrophy kar jayenge. Why? Because the ala flares when you breathe. If the ala is not getting utilized, they will become atrophied. If the ala becomes atrophied, your nose will become pinched. So there will be a pinched nose. There will be a pinched nose of the child. And why? Because of alar atrophy. The ala have atrophied. Right? Okay. Now what is the child breathing from? The child is breathing from the mouth. So the child will have an open mouth. The child will have open mouth breathing. Now simply understand one logic. Because the child has got open mouth, what is happening? Always remember, when the child's mouth is closed, the tongue always touches the gums to stimulate teeth. Whenever you see, children will keep rubbing their tongue to their gums. Why? Because that stimulates the dentition, that stimulates the teeth to come out. Now, when they don't stimulate the teeth, what is going to happen? Because their mouth is always open, so their tongue is not touching the gingiva. If the tongue is not touching the gingiva, what is going to happen? Their teeth that will come out will be very, very crowded. They will not be aligned. And if their teeth are not aligned, they will get crowded upper incisors. And if the crowding of upper incisors happen, if these teeth come out like this, your lip will come up. And that is called as a pinched upper lip. That's called as pinched upper lip. Because your teeth have come out in a very haphazard direction. Correct? See, everything is important here. Now, these children are not, they don't have a very beautiful face, right? Because obviously they've got so many gross features because of constant obstruction. So, hoga kya? These children, because they are not sleeping well also, they are having these kind of problems also. What is the second thing that is going to happen? During the time of sleep, they are having obstruction in sleeping. And because of obstruction, there is CO2 retention. And because of high amount of CO2, they have cloudy memory. So when they get up, they have morning headaches and they have got cloudy memory. That's why they cannot perform well in school. And if they cannot perform well in school, what is that called as? That's called as Guy's aproxia. Guy's aproxia means inattentive behavior. Many of the times, if you see one of the recent studies that was done in United States, they stated that most of the adenoid children get treated by child psychologists. The reason was inattentive behavior. So parents think that their child is not doing well in their report cards. So child has got attention deficit hyperactivity disorder. They take them to the child psychologist. Is the answer is the child psychologist going to answer this question? Answer is no. They are not having enough sleep. They are having carbon dioxide retention. Now coming to the most important point. What is the ear problem which can happen in these children? Now see and tell me. What is the ear problem that can happen in these children? I showed you that your nasopharynx has got another opening which is present on the lateral surface. Now see, can you see? This is a huge swelling present. Can you see the eustachian tube opening that is present is completely blocked? I'll show you. Can you see this? This eustachian tube orifice is hardly there. It's half of it is blocked. Why? Because such a big obstruction is actually closing that. Now, if there is going to be obstruction over the eustachian tube orifice, what is going to happen in the ear? Ear will get otitis media with effusion. Because the whole problem of the eustachian tube is that the eustachian tube cannot equilibrate the pressure between the external environment and the middle ear. And if it cannot, what will happen? It will cause collection of fluid inside the middle ear, that is called otitis media. So, if this child will have otitis media with effusion, what is going to happen in the child? The child will end up into conductive hearing loss. So what will happen in the ear? The child will end up into otitis media with effusion, which will lead to conductive hearing loss. That is why even if the child is getting, even if the teacher is teaching 10,000 times, they will never hear. Because the child is not having that. Right? So this is the most important sign. Now, no, not lighthouse sign. Lighthouse sign is not associated with this. That's seen in ASOM. In my previous lecture, I've shown lighthouse sign. Please go and see up that video as well in ear. Okay, so this is something which will lead to otitis media with effusion. You'll see bubbles behind. If you remember my ear VBQ, I showed also otitis media with effusion kaise hota hai, how that happens, right? So most common cause of otitis media with effusion in children is adenoid hypertrophy because of eustachian tube obstruction. That's how you link these things. Fine. So this becomes a very important MCQ. Now you need to carefully think and answer me. If I tell you these are the problems with the child: obstruction, breathing, snoring, and recurrent episodes of sleep disturbance. And what is the most common procedure you will do in this child? This child does not have ear features. So your answer should be endoscopic adenoidectomy. Finished. But agar maine thoda sa twist kar deta question, if I would have twisted it somehow, and I would have added this child has got conductive hearing loss, then will your answer be adenoidectomy alone? The answer would have been nahi. The answer would have been adenoidectomy with myringotomy. This would have been a better option. So please see if in adenoid case they ask you that there is a conductive hearing loss element also. If there is a child with nasal obstruction with conductive hearing loss, your answer to management will become adenoidectomy plus myringotomy. If they tell you that that particular baby only has got nasal obstruction as primary symptom, your answer will become adenoidectomy alone. Please be very careful because these two PYQs have been quite commonly asked. This is myringotomy, they put it as an option. Many of the people don't look up and they mark adenoidectomy alone. But whenever they give conductive hearing loss, please, the answer would be adenoidectomy with myringotomy. Okay, fine. Chaliye. So this finishes question number 9 and the important things around adenoid hypertrophy and what you'll see over in this phase. And what is this phase called as? This is called adenoid facies. Okay, this is called as adenoid facies. Fine. Chaliye. Now we move on to the next, and that is question number 10. That would be my last question for today, right? And that would finish up the nose VBQs and even the VBQ series from ENT's perspective. So this is about a 58-year-old man who presents with recurrent severe epistaxis. So this is about recurrent epistaxis. And despite adequate nasal packing, the bleeding is predominantly posterior and the patient requires repeated blood transfusion. So that means by packing, the patient is not getting any better. Endoscopic examination is performed under general anesthesia and the surgical procedure shown in the video is carried to achieve the definitive hemostasis. Which of the following surgical procedures have been demonstrated? So I have demonstrated a surgical procedure, right? Even if you don't know the surgical procedure, आप लोग इससे guess out कर सकते हैं कि मैं क्या कर रहा हूँ. The only epistaxis में procedure that we do is given in this option. Is it anterior? Is it endoscopic anterior ethmoidal artery ligation? Is it transnasal endoscopic sphenopalatine artery ligation, TESPAL? Is it internal maxillary artery ligation or is it external carotid ligation? So this is a patient who has got uncontrolled epistaxis, packing mein koi kaam nahi hua hai. Now we are doing a procedure over this patient and what we are doing over here, this is the procedure that you can see. So what I'm going to do is I'm going to show you, this is something which is extremely important from our perspective, right? This is maxillary sinus, what you can see over here. This is posterior wall of maxillary sinus, I'm inside the nose. Now you see, there is an artery which is coming from the posterior wall of the maxillary sinus. Can you see this artery? You see this artery coming out, which I'm exposing. See, this is the artery which has come out, right? Okay. Now, what is this artery that comes out from behind the maxilla? So, I'm taking this artery and what I'm going to do is, I'm going to see, I've taken a cautery and I'm going to buzz it. Now, you see some smoke will come out soon. And I've just held the artery and I'm going to buzz it. And that buzz is basically called as ligation. Basically, see, the smoke is coming out. I'm stopping the arterial bleed from happening. Now, what is this? This is the largest artery for epistaxis, right? The artery of epistaxis. What is this artery? Sphenopalatine artery. This is only one thing that we do, not anterior ethmoidal artery. No, this is sphenopalatine artery. Whenever ever I say epistaxis, the answer is transnasal endoscopic sphenopalatine artery ligation, not anterior ethmoidal. So the answer is TESPAL, not A, B. So whenever and ever we say this is transnasal endoscopic sphenopalatine artery ligation, right? What did I show you? Again, I'll show you. So this is the artery of epistaxis. If you don't remember anything, doesn't matter. Epistaxis means only one artery we will ligate inside the nose. And what is that artery? It is this artery. It comes out from behind the posterior wall of maxilla. See, this is the posterior wall of maxilla. I've opened the maxillary sinus completely. Behind the posterior wall of maxilla, there is an artery coming out. I'll just expose the artery again. See, there's an artery which is coming out inside the nasal cavity. Now, this is one of the major arteries which is basically giving its supply to the nasal septum little's area. तभी इसे arterial epistaxis भी कहते हैं. Doesn't matter. Sphenopalatine artery even supplies posterior part of the nasal septum, right? So, हमेशा Woodruff's plexus is not the answer, right? Okay. So, Woodruff's plexus is not always the answer. I'm talking about an artery over here. So, artery can have posterior epistaxis as well. Sphenopalatine सिर्फ आगे नहीं करती, पीछे भी supply करती है, right? So this is something, not always anterior epistaxis will be the reason for sphenopalatine artery. Posterior epistaxis भी होती है उसमें, okay? But most common cause अगर मैं पूछूं, तो उसके case में there would be Woodruff's plexus. But does this look like a plexus? This looks like an artery. और मैं artery की बात कर रहा हूं. So whenever I say Woodruff's and the answer is hypertension, the Woodruff's आ जाएगा. But when I say artery ligations, the answer would be only one. And that is only one thing that we do in epistaxis, and that is the artery of epistaxis, and that's TESPAL. ये मत बोलना. TESPAL is a very, very famous question that has been asked since a long, long time. Right? And that's what? That's called transnasal endoscopic sphenopalatine artery ligation. It's also called as the artery of epistaxis. And that is what? We take the artery, we seal it. And this is basically the one which is also called as the artery of epistaxis. Now, if this doesn't stop with this, then the next thing is we clip the maxillary artery. ये इसका second step है. Because maxillary artery की branch है sphenopalatine artery. If this does not happen, then we go on to the last one, that is external carotid artery ligation. So it's a stepwise procedure. Anterior ethmoidal is nowhere related with ligations. It's a very small artery. तो वो हम ligate नहीं कर सकते. So we don't do that. We only do this. These are the major ones. ठीक है, पहले TESPAL करेंगे, नहीं ठीक हुआ, then we go for internal maxillary artery, then not, then that is external carotid, final answer. Okay, fine. Chalo. So this finishes about my VBQs of ENT. We have done 30 important VBQs starting from larynx, then going into ear, and finally ending up with nose and nasopharynx. I hope you guys have enjoyed today's session. I got many answers. I'm quite happy that you guys are actually thinking like clinicians and answering. Always remember, this time rote memorization is not going to take forward. This time concept-based questions are the ones which will keep your brain ticking inside, and keep yourselves calm and cool. When you see the question, think around the question and answer. It does not matter, right? So it is just about the time that you take, think, answer. Don't panic, right? This is an exam. The exam is not going to leave you for life. This is an exam. Take it like an exam. It's not life. It's not life. Exams come once in a year. ठीक है, it's okay. But keep yourself calm. Even if you have a very bad day and if you are calm, you can convert it into a good day because your brain works more that time. So don't panic. Panic की वजह से आप आती जाती चीजों को खराब कर देते हैं. That's something that spoils the result. Don't think about the future, but one thing I would say to all of you, start dreaming, start manifesting that you're going to go into your dream college very soon. If your manifestations are very strong, then definitely you're going to end up into a very good college very soon. It's just about that small period of time. And one last thing is, at this period and at this stage, this is the point where you need to sprint. बस ये sprint वाला time है. You can't wait for the time. We are going to come up with marathons very soon. This is the time where you need to sprint and you need to, think of everything. जितने भी आपके problems हैं, वो सब side कर देनी है. आपको बस एक tunnel vision रखना है that my goal is in front of me and I have to achieve that and I don't have anything else to bother about. Bothering is rest of the people's job. Let the NB bother about the result, not you. Right? So again, think the controllables. Controllables are आज मेहनत करनी है, आज बैठना है, आज करना ही करना है. That's what your preparation should be. Now, अब मैं देखता हूं questions क्या पूछे गए हैं. PYTs are still reliable for exam. PYTs are always reliable for exam. Right? PYTs, PYQs के पीछे मत भागो. आपका काम है कि जितने इंपॉर्टेंट टॉपिक्स हैं वो PYTs हैं, वो हमें करने ही करने, right? So don't bother about those 5 questions which will be out of syllabus. They are going to be out of syllabus for every possible person. तो वो सबके गलत होंगे. But जो मेजर फोकस होगा ना, that's not going to change. Even if NB is down to 180 questions, they are not going to change the question. See, they are examiners are not, are those people who are very lazy. नए question नहीं बनते हैं. Questions will be the same. They are going to increase the length of that question. अगर मैं म्यूकर का एक क्वेश्चन इतना बड़ा बनाता हूं, I'll make it this big in order to waste your time. Now, if I want to waste your time, what will I do? So again, I'm telling you, if you get a very big clinical stem, don't start reading from the first line. पहले last line पढ़ना. What they are trying to ask you. Your brain always tries to find out the answer if you know what they are asking. Now, they will tell you a huge stem like this. Patient came from Gorakhpur, 55-year-old, went to this place, then had food, then came back home, then had epistaxis. You don't need that much history. वो waste करने के लिए history दी गई है. What you need is, see in the last line what they are trying to ask. They are trying to ask what is that? Management. मतलब, try to find out the keywords. Maybe management आपको 2 line में समझ में आ जाए. That what they are asking. So this is what exactly is your approach should be. Long clinical stems always see what they are asking first. Then go and read the question. Okay? Time yourself very well before your exam, when your exam is there. Mark only those questions which you feel कि आप answer कर लो जाओगे. But yes, your marking should be high. Attempts should be high. Attempts कम मत रखना. This is what is also very important. Now, East India is saying, panicking the whole day left better after listening. Oh, thank you so much. So don't panic. That's what I'm saying. कि आपके आते जाते results खराब हो जाएंगे. आपने देखा है when you are doing skydiving. तो skydiving में क्या करते हैं? You are sitting on the ledge of the plane, right? आज अभी आप लोग उस ledge of plane पे बैठे हैं, आप नीचे देख रहे हैं, आपको बहुत डर लग रहा है, right? And it's a very tension वाला scenario कि नीचे क्या होगा. I want you all to just jump off from the plane. Don't bother about क्या होगा. You will have the best time of your life. When you jump off from the plane, you're outside your comfort zone, you're trying your best, that's what matters. आपको एक simple सी बात बताता हूँ as a senior. When you're a doctor, right, at 35-36 years of age, आप सब consultants हो गए. You'll be having your own clinics, you'll be having your own businesses, आप सब के सब settle हो जाओगे. तो ये rat race में भागने की जरूरत नहीं है. Everybody will take time to settle down. It's just about that nerve, मुझे अभी करना है. We get into that zone कि अभी करके सब खत्म कर देते हैं. But don't get into that zone. It's just about take your nerve, cool it off, सब सही होगा. It's all about life. Life is just not about NEET PG यार. Life बहुत कुछ है. So you need to do everything in life, right? But this is an important segment of life, so we should be very much, we should give everything to the process. If we give everything to the process, nature will gift us back. That's how nature is, right? What should be the number of attempts for new pattern? Again, that does not matter. It should be at least 165 plus. 160, 165 plus. Don't leave more than that. Because क्या होगा? Then you will come down on the competition. Attempt higher होगा. Again, अगर आप एक क्वेश्चन सही करते हो तो आप 4 मार्क्स पाते हो. अगर आप एक गलत करते हो तो आपका एक नंबर गलत होता है. But इतना खराब तो दिन नहीं होगा that you get all your, whatever you feel or what your gut feeling says, सारे गलत हो जाएं. So always the probability of getting those number of highs are high, right? So don't leave out on a lot of questions and come back. Attempt should be higher. जो question बिल्कुल नहीं लगते आते हैं, leave them out. But again, go with the gut feeling. If you feel दो options के बीच में you feel that the right answer is this, attempt that and come. Don't leave out a lot of questions because again your score will get down in that, right? Chalo. So this finishes my session and this finishes the whole of ENT. Right. How many number of CRCTs का मतलब I don't understand. So again, it does not matter. अभी 180 में कितने सही होंगे अब देखो हमें भी नहीं पता. What exactly is the pattern? Like we don't even know. We are also going to face it for the very first time as educators. हमें दिखेगा how tough the paper is. But yes, if the person has got number of corrects अगर आपके high है तो definitely you stand out a very good chance, right? So it all depends on paper to paper. But अभी मैं कह रहा हूँ 70 to 80% of the paper will be regular paper. जो 20% होगा ना that is going to be tricky. It's not going to be the whole paper is tricky. They can't be INI-CET standards, right? So ये पूरा paper tricky नहीं होगा because there are a lot of people who are sitting as a competition. आपकी जो fight होगी ना वो होगी again उन questions पे जो revision कम हुए, right? So this is something where जो जितने भी आपके revisions सही हुए, जितने आपके revisions हैं वो सही होने चाहिए, क्योंकि that kind of confusion between two options is the one which kills your rank, right? So अभी revision strong रखो, don't read anything new. See what your teachers are telling and in the end, जो भी marathons आएंगी from our side, just sit and finish the subject with us. That's what we will tell you. Okay? So this is all from my side. Again, wishing you guys all the very best. Keep hopes high, keep manifesting high, keep dreaming high, and definitely I wish that all of you will definitely come out with flying colors. Don't run behind the uncontrollables. Run behind the variables which are in your control. Don't panic and definitely you will all be on the other side very, very soon. Chalo. So see you all in the other session very, very soon. Thank you all for joining. Thank you.